Hi, my name is Josie Feeney, and this is my Sports Med 3 project for Rehab on a distal bicep tear. The mechanism of injury for a distal bicep tear is like a popping sensation. It's normally like a quick jolting movement, and it's very common when lifting heavy objects, so you see it a lot in weightlifting. There are two different surgeries that can be done to fix a distal bicep tear, and that is either a repair or a reconstruction. A repair is where they reattach the tendon to the radius. This is done immediately after the injury, about 4 days, and surgeons will either do a single incision. A single incision is going to be on the inside of the elbow, and a double incision will be across the middle of the elbow, and then another incision on the outside of the elbow. And single versus double is surgeon preference, but the gist of it is that they take any damaged tissue of the bicep tendon and reattach it to the radius using surgical buttons or certain strong sutures. A reconstruction is where they completely replace the bicep tendon. This is done typically when the injury has been neglected or it's a re-injury to the bicep tendon. So if you already had a repair, then they're going to do a reconstruction. This can be beneficial if you're going to be more aggressive with how you're going to use your arms. So if you're an Olympic weightlifter, you might want a reconstruction over a repair versus if you're just doing day-to-day tasks. This is pretty much always going to be an allograft, so cadaver tissue, and it's going to be the semitendinosus, which is found in the leg. And this is again single incision, and a single incision is on the inside of your elbow, and a double incision is going to be across the elbow and then on the outside of the elbow. With a reconstruction, they're going to suture the graft to whatever remains of the biceps tendon and then attach the graft to the radius. Phase 1 after surgery is going to be 0 to 1 week after surgery. Your main goals for this are going to be to reduce pain, swelling, and protect the repair or the graft. There's going to be no lifting. You're going to be non-weight bearing on your arm. No flexion or extension, obviously, and no pronation or supination of the wrist. You're going to use modalities like ice and compression to reduce the pain and swelling. You are going to do some grip strengthening of your hand. The patients are always going to be in a fixed hinge brace like this at 90 degrees for the first week. Again, non-weight bearing, and another modality that's used would be an NSAID like an ibuprofen or any pain medication that a surgeon would prescribe. Phase 2 is weeks 2 to 6. There's a progression to not using a brace. Your goals are, again, to reduce pain and educate your patient on the goals and expectations of rehab. And again, get your patient's goals, whatever the PT's goals are, surgeons' goals, surgeons' programs, to make sure everybody's in the loop and everybody knows what's happening and everybody's on the same page. This is where you're also going to focus on a progression from passive range of motion to active assisted range of motion to active range of motion. With the brace, with the progression, in week 2, you're going to go from 90 degrees to a full flexion. And then third week, you're going to go from 45 degrees of extension to a full flexion. Fourth week, 30 degrees of extension to full flexion. Fifth week, 20 degrees of extension to full flexion. And then the sixth week, you're going to completely disregard the hinge brace, again, as patient tolerated. This is kind of looking in like a perfect view with like some rosy tinted glasses on everything going to plan. You're going to focus on pronation and supination and flexion and extension as allowed by the brace, again with passive range of motion to, again, some active assisted range of motion to active range of motion as patient can tolerate, as is advised by the surgeon and the PT. Week 2, elbow flexion and extension, passive range of motion within the confines of the hinge brace, pronation and supination, keeping your elbows at 90 degrees, and active range of motion in the shoulder as needed, avoiding hyperextension. That's going to put more strain on your elbow. So you can kind of see in these pictures right here, like the pronation and supination, and like shoulder movement. Week 3, wrist and hand active range of motion. You want to make sure that your hand is moving, kind of start that rehab, get muscles moving, and passive range of motion with flexion and extension, again with however much the brace is going to let you move. Pronation and supination, keeping your elbow at 90 degrees. Pretty much the same as week 2. 4, pronation and supination, passive range of motion, keeping that elbow at 90 degrees, flexion and extension, active range of motion in a gravity eliminated position. So this is where the arm is supported, so it's not being weighed. You don't have to hold your arm up and move it. Somebody else can hold your arm up and you can only focus on flexion and extension. This is going to be super helpful because you're going to get the movement and you're going to start to kind of get those muscles engaged but not put too much strain on them. Weeks 5 and 6 are going to be the same. Pronation, supination, active range of motion at this point. Again, 90 degrees, flexion, and forearm supported at week 5. You want active range of motion in the gravity eliminated plane. So again, the arm is supported with the patient moving the arm on their own, but your arm is going to be supported. Eliminating the hinge brace. You're going to progress to be going against gravity in the hinged elbow brace with removal of the brace for active range of motion in full and painless against gravity. So you're going to progress from week 5 to 6 to not using the gravity eliminating plane to being able to flex and extend your elbow without it being supported. And again, pronation and supination, you want that to be active range of motion. Elbows at 90 degrees, flexion without support. No brace, no other person holding it up to reduce the gravity. And then moving on to phase 3. This is weeks 7 to 10. You're going to stay non-weight bearing till week 8. You still want to protect the repair, and you're going to gradually increase to weight bearing. You're going to continue range of motion exercises from weeks 2 to 6. You're also going to focus on a push-up progression. So that's going to be starting off with wall push-ups, going to maybe a table push-up, to knee push-ups, to maybe a full push-up on the floor. Wall slides, such as these, where you can see she's extending her arms up and down on the wall. This is going to, again, kind of start strengthening and stabilizing the bicep and the elbow without putting too much strain on it. Scapular protraction and retraction. Again, this picture is showing it on the floor. This is basically a scap push-up, if you've heard that in the weight room or anything. Again, you do this on the wall, do this just laying on the floor without being supported on your forearms. Couldn't find a picture of that. And then again, another wall slide progression would be with a band. You could start no band and progress the weight of the band. And just going up and down. This is going to start helping to stabilize the muscles. And then phase 4 is weeks 11 to 15. This is the transitional phase. This is where we're going to kind of start to strengthen what our muscles is. So we're going to increase our function, increase our strength, and this is where we're going to start to return to daily activities. We're going to start to do from weeks 10 to 12 a resistive range of motion. So that's again with a band or maybe a weight. You're going to do some bicep curls, pronation, and supination exercises. Again, resisted with a band or with weight, and also start on some tricep extensions. This is again, you're going to start with either a really low band weight or a really low weight of a dumbbell and progress to a higher weight of a band or a higher weight of a dumbbell. And then weeks 13 to 15, this is where you're going to start strengthening exercises. Shoulder strengthening, upper body strength training, upper body rows, bicep curls. Those, I think everybody knows what those look like. And then IYTs, this is where you start moving your hands in kind of this progression that it's shown, laying on your stomach, and then this can be done weightless with nothing, just movements, and then you can add banded to make it resistive or add weights to make it strengthening. And then phase 5 is going to be returning, or phase 5, months 4 to 6, is going to increase strength and activity to normal, and this is going to where you're going to start returning to a sport. So this is if you're an athlete, you're going to do sport-specific exercises. So obviously, if you're a soccer player, it's not going to be as intensive as if you're a pitcher for baseball. You're going to continue exercises from phase 4. You're going to introduce plyometric upper body exercises, such as throwing a ball. That's as much of a plyometric as you can get for upper body, really. And you're going to start increasing weight, getting stronger, but still wanting to protect your repair, protect your graft, take it easy. And you're not going to be able to go full throttle, but you're definitely going to start getting progress. And then phase 6 is going to be after month 6. This is where you're going to increase strength, kind of get back to whatever normal weight you lift. If you're lifting weights regularly, you're going to fully return to your sport, regular practices, regular games, as much as you can if you're doing good. Sport-specific exercises, regular training. So like if you're a weightlifter, you can probably get back to your normal weightlifting routine. Thanks for watching. I hope you learned something about a biceps tendon repair and rehab.